Antimicrobial resistance is a significant, escalating threat to global health. For hospitalized children, the priority is clear: get them off IV antibiotics as quickly and as safely as possible. But pediatricians are often forced to act in an information vacuum. Because infections can spiral so quickly, doctors typically prescribe antibiotics immediately, relying on a common blood biomarker called C-reactive protein, or CRP, to gauge the severity of the infection. The problem is that CRP is a blunt instrument. It lags 12 to 24 hours behind the actual bacterial load, and it often fails to differentiate between a serious bacterial infection and a viral one. This graph illustrates that biological delay. While the bacterial load might surge in real time, the CRP response is slowly creeping up a full day behind. That gap creates a fog of clinical uncertainty. Without real-time data, doctors understandably keep children on IV antibiotics longer than is necessary to avoid taking any risks, unintentionally driving the very resistance crisis they're trying to manage. To clear that fog, the medical community looked toward procalcitonin, or PCT. Biologically, PCT is highly specific to bacterial threats. It spikes almost the moment bacteria enter the bloodstream and drops as soon as they are cleared. This graph shows how PCT mirrors the bacterial load with high precision and drops sharply to zero once the infection is neutralized. By identifying when that drop occurs, physicians can stop treatment at the earliest safe moment, saving dozens of hours of unnecessary antibiotic exposure. The batch trials set out to prove this hypothesis, that using a PCT-guided algorithm would allow doctors to safely reduce thousands of hours of IV treatments across the healthcare system. This theory was put to the test in the UK National Health Service batch trial, a large-scale pragmatic study designed to see if the biomarker worked in real-world hospital settings. As this trial profile shows, the scale of the study was extensive. Out of 15,000 screened patients, nearly 2,000 children were randomized into either the PCT group or a usual care group. With a superior biological indicator in hand, the expectation was a dramatic reduction in total IV hours for the children in the PCT group. But the results were unexpected. Children in the PCT group averaged 96 hours on IV antibiotics. The usual care group averaged 99.7 hours. This bar chart shows how narrow that gap actually is. A 3.7-hour difference in a multi-day hospital stay is effectively negligible. Despite using a more sensitive and expensive test, the PCT algorithm failed to significantly compress the treatment timeline in practice. This raised a question. Was the problem the biomarker itself, or how it was used? Adherence data from the trial reveals a significant hurdle. Only 24% of cases in the PCT group were managed strictly according to the algorithm's guidelines. Much of the friction was logistical. Blood samples had to be processed in a lab, and frequently the PCT results simply didn't reach the doctors in time for their morning clinical rounds. There was also a psychological barrier. Many clinicians were unfamiliar with PCT. When treating a sick child, they were often hesitant to trust a new algorithm over their own caution, resulting in a refusal to stop antibiotics even when the test suggested it was safe. It demonstrated that a highly precise biological marker is functionally useless if the human system it operates within cannot or will not act upon its data. While low adherence played a role, it wasn't the only reason the trial stalled. There was a substantial hidden variable at play. The lead hospitals in the batch trial already utilized highly robust pediatric antimicrobial stewardship programs. These specialized stewardship teams are incredibly efficient. Through twice-weekly rounds and constant chart reviews, they are trained to hunt for every possible opportunity to safely de-escalate treatment. As this gauge illustrates, while standard care might involve overprescription, hospitals with these specialized teams were already pinned deep in the highly optimized green zone. These clinicians were already so vigilant that they had reached the limits of efficient antibiotic use long before the PCT biomarker was ever introduced. They had hit what researchers call the stewardship ceiling, the absolute biological and mathematical limit where you cannot reduce a child's antibiotic duration any further without risking their safety. This chart shows the reality of that limit. At peak efficiency, both usual care and the PCT algorithm hit the same floor. The algorithm didn't fail. It simply equaled a human protocol that already solved the problem. There is considerable potential for these algorithms in hospitals that lack dedicated stewardship teams, or for specific patient subgroups where the clinical signs of infection are harder to read. But the final lesson of the batch trial is that technology cannot replace systemic excellence. Sometimes the most powerful asset in a hospital isn't a new test, it's a dedicated team doing their job perfectly.
If you like this video, give us a thumbs up.